Bismillahirrahmanirrahim. Respected teachers and dear colleagues, Assalamu alaikum. The topic of presentation is complex cardiac interventions in heart diseases. Any patient with cyanotic congenital heart disease or post-surgical patients with post-surgical sequelae requiring interventions comes under the category of complex cardiac interventions. Respected teachers, I am here just because of my mentor, Brigadier Madullah, who gave me the confidence of performing such complex interventions. I am going to present a few interventions which were performed in grown-up patients. More than 1,000 cardiac catheterizations were performed during the last 4.5 years, and 62% were therapeutic. My first patient, 50 years old female, who presented with signs and symptoms of right heart failure. Echocardiography showed dilated hypertrophied right ventricle with severe RV dysfunction, and there was bilateral branch pulmonary artery stenosis. You can appreciate that left pulmonary artery is almost hypoplastic at the origin, and there was a little bit of dilatation at the hilum. And there is severe stenosis at the origin of right pulmonary artery, and there was post-stenotic dilatation. So it was quite challenging. The first stent was, after wire deployment, was taken into the left pulmonary artery, but unfortunately the stent migrated. And then I took the balloon-mounted stent, and after checking, the stent was deployed at the origin of left pulmonary artery. The right pulmonary artery was addressed with the balloon dilatation. And this was the post dilatation and stenting result. And the patient was discharged home, and her signs and symptoms of right heart failure improved and was on regular follow-up. My next patient was 40 years old male who had total correction 30 years back, and he just presented with shortness of breath with NYHA class 3. And there was a large residual VSD patch leak, and this is LV angiogram showing a large patch leak. And after crossing this defect, making arteriovenous loop, 20 millimeter VSD device was selected, and the device was deployed at appropriate pace. And after deployment of device, this is the LV angiogram showing well-placed device with a slight residual leak. The device was released, and this is the aortogram showing no aortic valve regurgitation. The patient was discharged home. My next patient, 35 years old, female who had severe mitral valve stenosis. She underwent PTMC, and during transseptal puncture, the needle perforated the aorta. And then the needle was removed, making arteriovenous loop. 6 French delivery system was passed, and 6.4 millimeter MFO device was used to close this rent. This was the device placement, and the device was well placed, and there was no residual leak, and right coronary angiogram showed unobstructed blood flow. Next patient was 20 years old female, was diagnosed as a case of perimembranous VSD with large pouch, and the device selected in this case was PFM Nataclute. So after making arteriovenous loop, the device was deployed, 8/6 device was selected, and after confirming the device position, the device was released. And you can see that there was a slight residual leak, but on the next morning the patient started having dark urine which turned into red urine, and this patient required RCC transfusion as well. So we were quite worried whether we should go for surgical exploration for this patient, or we have to go to this patient to the cath lab and retrieve this device. So we took the patient to the cath lab, and transcatheter retrieval with Maslanka was done with of PFM net occlude. And after that, on the same setting, we again passed trauma wire and making arteriovenous loop, and the defect was closed with the 8 millimeter VSD device with good result, and patient was discharged home. 12 years old female who was having tricuspid ataxia with normally related great arteries. She was palliated with bidirectional gland shunt and was planned for Fontan completion. And during cardiac catheterization, showing there was a severe LP origin stenosis, and there was 5 millimeter pressure gradient across this stenosis. And this has to be addressed, otherwise the patient will go into Fontan failure. So 26 millimeter stent was mounted on the balloon and was deployed at appropriate site. And after deployment, this was the final result. There was no gradient. The patient underwent Fontan completion and is on regular follow-up. Next patient, 16 years old boy who had total correction 14 years back, and he also started having breathing difficulty 3 months back. 2D echo showed right coronary artery to RV fistula. Initially, I thought that is fistula, but angiogram showed a tubular sac arising from the aorta and connecting to the right ventricular outflow tract. And RCA looks to be fine. So next, I gave the injection into the RCA region. It was fine. There was no fistula. So it was ruptured sinus of Valsalva aneurysm into the RV cavity. So making arteriovenous loop, the 10-8 millimeter 10-8 PDA device was selected to close this defect. And this is the final position of the device, and there was no residual leak. And echo was done after the device closure. This was the tract, and this is the well-placed device in the RVOT. 6 years old boy who was diagnosed case of tetralogy of Fallot, and he was having frequent episodes of spell, and the pulmonary vasculature was quite small, so he was not a perfect case for total correction. So at this stage, the child requires some sort of palliation, whether go for a BT shunt or RVOT stenting. So we planned for RVOT stenting. So you can well appreciate that infundibulum is quite tight, and there was quite narrowing in infundibulum. So balloon dilatation would not help in this case, and so RVOT stenting was done in this patient. So this was the stent. This is LO view. LO90 view showing well-placed device stent, and there was no pulmonary regurgitation. It was quite well below the pulmonary valve. So this is the final position. Patient was discharged home. And next patient is a 32 years old female who had mitral valve replacement in 2014 and second surgery in February 2022 with mitral valve replacement. She has got a severe paravalvular leak, and with ongoing hemolysis, for which she required multiple transfusions. So planned for the gradient across the mitral valve was, the mean gradient was 17.5 millimeters mercury. So transcatheter device closure of paravalvular was planned, and after transseptal puncture the sheath was not passing through, so the transseptal puncture was dilated with balloon, and after that the steerable sheath was passed, and the paravalvular leak was managed to cross this the trauma wire through the paravalvular leak and making arteriovenous loop. 7 French delivery system was passed, and 1210 MFO device was used to close this defect. This is the T showing well-placed delivery system with slight residual leak, and then the device was placed. This is the angiogram, and this is the final position of the device with slight residual leak, which next 24 hours it abolished. This is the final position on the angiogram. Next patient is 24 years old female who had surgical closure of VSD with RV band resection. Immediately after the surgery, she had episode of mediastinitis, which recovered with the oral antibiotics. And 3 months after that, she suddenly developed retrosternal pulsatile swelling. Echo showed a pulsatile swelling in the retrosternal area. Immediately, she was taken to the cardiac CT was done, which showed a large pseudoaneurysm, and neck of the aneurysm was there, but it was quite close to the innominate artery. You can appreciate that it's a quite large pseudoaneurysm. And this is the 3D imaging showing large pseudoaneurysm, ascending aorta, and innominate artery. So planned for transcatheter closure of this pseudoaneurysm. Angiogram showing large pseudoaneurysm and close to the right radial innominate artery. So right radial artery was taken to just to check that we should not close this during transcatheter device closure. To a 14 millimeter delivery system was passed, and you can appreciate that there was a kink in the sheath. So it was quite difficult to manipulate the device through this sheath, but finally we were successful and deployed the distal disc into this pouch and the proximal disc into the ascending aorta. And this is the final angiogram showing a good flow into the innominate artery. And after the device closure, this was the CT about 3 months after that, well-placed device without having any obstruction to the innominate artery. And this was article published in Vascular Diseases and Therapeutics. Take-home message is early recognition and prompt response to the complication is a key to success. Thank you very much.